Hello, everyone. Good night. Welcome, everybody, to this first session of our sign discussions. This project is organized by the sign chapter at the Universidad Nacional Mayor de San Marcos from Lima, Peru. And this project is released and the discussions are elaborated in English just because the aim of this project is to disseminate the contents that we are going to be developing among the medical student community, the international medical student community. And in order to do that, we want to do it in English so it can reach a broader audience. And yeah, well, to start, let me introduce myself. My name is Gerardo Luna Peralta. I'm a medical student. I recently finished my 5th year, and next year I'm starting my 6th year. Here in Peru, we have 7 years of training. And well, I'm very happy to be here. I founded the science chapter of my university a couple of months ago. And this project is really close to my heart because I've seen it grow throughout the months. Because in our science chapter at San Marcos, we have been practicing for the last months in order to do proper discussions. And I think we've done a great job with all the people that have been involved so far in this project. So this project, as you may have seen from the flyers that we have already put out, consists in one case presenter. The case presenter is going to present a case that is not necessarily a real case that the medical student has encountered in a hospital, for example, but it can also be a clinical report or other sources that can be used, because the purpose of these sessions are for us to learn among peers, as said in the message. And well, we also have 2 case discussants in this opportunity. For this first session, the case discussants are going to be Arturo Ruiz, which is also here, and myself. And we also have one teaching points writer, which in today's sessions is in charge of Sandra Uriol. And obviously the case presentation, it's going to be in charge of Jeffrey Mora. Sorry for forgetting to mention your name, Jeffrey. And also the case schema developer is going to be Jeremy Ladines. So if everyone is right now at the meeting, I think that is the case. I think we can present each other, but first, obviously, let me introduce you to my co-discussants for today, and a really critical piece for this project, Arturo Ruiz. Please introduce yourself.
Thank you, Gerardo. Yeah, hi everyone. My name is Arturo Ruiz. I'm finishing my 4th year of medical school. I'm going to start my 5th year the next year. And well, as Gerardo said, this project is really with the aim of creating collaborative knowledge of neurology, because I think in our group, all of us love neurology, and I hope all of you also have a little bit of interest in this field, because it is very amazing, really. And that is why we're making these sessions. We really appreciate the value of clinical discussions. So as Gerardo said, we have been doing some sessions the months before. And with all that, we have come with a relative experience to do a great job, hopefully, today. So I think I can give the word to Jeffrey. If you can present also yourself, Jeffrey, go ahead.
Yeah, thank you, Arturo. Hello, everyone. Just as Arturo said, I'm also a 4th-year medical student. I just finished internal medicine, which includes neurology. And as each member of the science chapter, I am a neurology enthusiast. And I'm also really excited to be the first case presenter. of our science chapter at our university. And just as Gerardo and Arturo, I also hope that this project will provide medical students from our university the clinical tools to think neurology in a better way, perhaps more organized way, and also to recruit students who also have a passion for neurology. So again, I'm really excited and thankful to be the first case presenter.
Lovely to hear you, Jeffrey. I think we can continue with Sandra, who is in charge of the teaching points. If you can open your mic and do an introduction of yourself, please.
Yes, well, hi everyone. My name is Sandra Uriol. I am a fifth-year medical student, and I am so grateful and happy and excited to be here, being part of this first science discussion team. I already heard past discussions with Gerardo, Arturo, and Jeffrey, and I can tell you this is going to be a very productive and a very interesting discussion, and you are going to enjoy it. So that's all I'm going to say. I'm so happy to be here and see this project grow since the start, and now is possible to see how it's growing.
And for the final presentation, we have Jeremy, who is in charge of the case schema. If you can open your mic and introduce yourself, please.
Yes. Good night, everyone. Thanks, Gerardo, for the pass. Sorry if I can't turn my camera. I have my internet. This is unstable. My name is Jeremy Ladines. This year I finished my fifth year of human medicine, together with Gerardo and Sandra. And on this occasion, I was offered to have my role as creator of the summary of schema, the summary scheme of this discussion that I know will be very productive for everyone present. Thanks.
Thank you very much, Jeremy. Yeah, even though the team for today's session have just presented themselves, everyone is encouraged to participate at any time during the discussion. You can raise your hand or you can use the chat to communicate everything that you that goes through your mind. You may be able to discuss different possibilities, diagnostic possibilities with your peers that are also watching the session. And yeah, we really encourage that type of participation because it is going to be the most fruitful for everyone. So I think we can start. The only piece of information that we have known so far from this case is that it is a case of weakness of all the limbs. But the rest of the information, Arturo and I are going to learn more about the case right now with you all. So yeah, we are very excited to get to the bottom of this case. Yeah, Jeffrey, you can start presenting if you have the permissions to do that. We are already recording, so it's okay.
Okay, thank you, Gerardo. So we're going to start a case, first presenting the chief complaint, which, as Gerardo mentioned, most of us in this meeting already know it. And I'm going to be presenting information chunk by chunk, and Gerardo and Arturo we're going to be discussing. So the first piece of information is that a chief complaint of today's session is a woman presents with weakness of all limbs. So I think I can pass it to you guys.
Yeah, I don't know if me or Arturo should start. I think Arturo, if you want, you can start, and then I can do a comment on what you mentioned.
Yeah, it's okay. Okay, so weakness of all limbs. In neurology, weakness is a very common symptom we see in a lot of cases. But this type of weakness, we have to say that is very particular, because not all the days you see a case of weakness of all limbs. It involves specific levels of lesions. But generally, we can approach it the same way we develop weakness. And we discuss weakness usually in our group, focusing first if it is in the central nervous system, or if it is in the peripheral nervous system. So I am going to mention now some causes of central nervous system diseases that can present with weakness of all limbs. As I said before, we can see weakness in a lot of patients by focal lesions. Focal lesion, for example, for an ischemic stroke, can present with a weakness in one limb or as an hemiplegia. But weakness of all limbs as a central nervous system disease is very particular, because, or at least you can imagine that being the brain divided in two hemispheres, one hemisphere controlling each side of the body, for we seeing a patient with weakness of all limbs, the lesion, at least if it is in the brain, it should be in both sides of the brain, and that is very, very rare. We don't usually see those type of pathologies unless it is with a disease that can cause multiple strokes in the brain. For example, a vasculitis of any cause. For example, a primary vasculitis of the CNS. Perhaps it can cause multiple strokes in the brain that can present with a weakness of all limbs, but it is very, very rare. A more common lesion in the central nervous system is at the level of the brainstem, specifically at the pons. In the pons, we see a syndrome that is the locked-in syndrome, which is a case, or which is a clinical presentation with a patient that can move any of his limbs, that can move any of the muscles of the face, and can only control the eyes. And that is very specific for a lesion in the pons. In some cases, we can see locked-in syndrome with a Wine-Smile progression. That means a progression in the weakness that starts, for example, in the left leg, that then progresses to the left arm, and then to the right arm, and then finally to the right leg. That is a Wine-Smile progression, and that is sometimes associated with a locked-in syndrome. And that is one of the examples of lesions, of clinical presentations in the pons that can present with that. And that is usually caused, for example, by stroke, either ischemic or hemorrhagic. Other causes can include, for example, compression of the pons by a mass, by a hematoma, either being it's epidural or subdural, can also compress the brainstem, can present with this clinical presentation. And also other lesions of the brainstem can include, for example, compressions from tumors, compressions for abscess, and also some presentations of demyelinating diseases. For example, NMO can cause disease at the level of the brainstem. We can also see multiple sclerosis causing quadriplegia by affecting the brainstem. And if we look a little bit down from the brainstem, we can see all the spinal cord. And in the spinal cord, for us to see a weakness of all limbs, it has to be a little bit above of some level, and that is usually the C5 level of the spinal cord, because if the lesion is below that level, the patient won't have weakness in the arms, and will probably only have weakness in the legs, probably with some sensory level at the thorax or at the abdomen. But for us to see a patient with weakness in the legs and in the arms, the lesion have to be above C5. So above C5, what causes can we see that can present with weakness of all limbs? The most classic presentation, probably, as you have already imagined, is trauma. Trauma with direct damage to the spinal cord can present with weakness of all limbs if it is above C5. Other causes can include, for example, tumors originating in the spinal canal that can compress the spinal cord, can also present with this. Other causes also transverse myelitis should also be, we should also see have to this presentation in the mind, and that can be caused, as I said before, by NMO, by multiple sclerosis, by MOGAD, by also lupus can present with direct spinal damage, and can also present with weakness of all limbs. And that is pretty much as I have to say for central nervous system. I don't know if, Gerardo, you want to continue with peripheral nervous system causes of weakness of all limbs.
Yeah, thank you so much for your brilliant thoughts. I think you did a really good job summarizing the main causes that we should consider in terms of in an anatomical approach, right? Because when we see weakness, we first have to ask, is this a true neurological weakness, or is this just a subjective feeling of the person? Maybe the person is having asthenia, which can be a consequence of pathological processes that are not affecting the motor system, but are rather affecting other parts of the patient's consciousness. But if we are talking about true neurological weakness, as Arturo said, and as we know from neurological literature that really emphasizes on us considering two variables, the pace and localization, in the case of weakness, it is very important to have established what are we suspecting to be for the lesion to be localized. And yeah, you did a very important job at talking those possible localizations. If we have an acute quadriplegia, it implies that both of the corticospinal tracts in both sides of the body are impaired. And one quick approach that we can have is the upper motor neuron lesions that are obviously above C5, because in C5 we see the start of the brachial plexus. But actually, if we have lesions below C5 but above T1, you can also have a segmental involvement of the nerves of the brachial plexus, just because, for example, there are some nerves that have a representation of C5, C6, there are others that have C6, C7, C8, and those are, and the anatomy of the brachial plexus is very complex, but I just wanted to say that the brachial plexus, it starts in C5 and above T1, and depending on which exact part of the spinal of the spine is affected, then we will see the motor compromise. But let's not lose focus on those specific nuances, but try to remain looking at the big picture here. So far, what the information that we know right now is that we have a quadriplegia in a woman. It will be very important to know the age of the patient, and obviously the family history, past medical history, and obviously the neurological examination is going to be key. But I just want to emphasize that when we are analyzing a case, it is important to also highlight these important pieces of information that can allow you to establish a better differential diagnosis. For example, I think the age is going to be crucial for us to invoke possible etiologies like stroke, or other possibilities like degenerative disease that can cause compromise of the spinal cord as well, and also maybe risk factors for immunological disorders that can point towards multiple sclerosis or NMOSD, as it has been mentioned that those causes preferentially affect the brainstem. Yeah, so based on those in that data, we are going to be able to establish a better, more targeted differential diagnosis. And I think, since Arturo brilliantly covered every part of every anatomical part that we should consider on that we should first consider. And then I think we can receive more information from Jeffrey. And please give us the information.
Yeah, sure. So great discussion so far, guys. I'm really liking it. So I'm going to release the information about the primary history of this patient. So we have a 47-year-old woman, and she's presenting to the acute care service, and she refers weakness of all limbs that has been progressing for the last 3 months, like barely, roughly 3 months, because it is specified as 10 weeks, more or less, and it is intensified when going up and down the stairs. She also presents ataxia or ataxia, and she refers that she walks as she were drunk. She also presents nystagmus, vertigo, and refers feeling a diffuse burning sensation. On the last 3 weeks, going closer to today, the weakness has intensified up to the point where she's having difficulty walking.
Okay. Thank you so much, Jeffrey, for this piece of information. And it is actually a very rich case in terms of neurological signs. And yeah, right now I want to make a comment on everything basically that you've mentioned, but let's try to keep to don't lose focus of the case. So we have a woman that presents with seems to be chronic weakness, because it has been going on for the last 3 months, and the weakness is intensified when going up and down the stairs. So that can be described as a weakness that is fatigable, and that is very characteristic of some diseases, but obviously I'm just going to mention it, but we shouldn't anchor on this diagnosis. Myasthenia gravis is known for causing this fatigability in the weakness, which means that the more you exercise, the more pronounced the weakness is. So that is a diagnosis that we can have in mind, but we also have other signs. We have ataxia, and we have specifically gait ataxia. So when we are talking about ataxia, one first step towards the differential diagnosis will be to classify this ataxia between, is this a cerebellar ataxia, or is this a sensory ataxia? Because those two can be really differentiated on the outpatient setting. Just performing the Rumber test could be a useful test for differentiating between those ataxias. But if we see this case as a problem that involves ataxia, weakness, nystagmus, vertigo, there are really a short differential diagnosis that comes to my mind, and I think this actually has a very well-known triad, which is the Charcot triad, but the neurological Charcot triad. If someone please correct me on this, but I think we have all the 3 elements of the Charcot triad, which is not the same as the acute cholangitis triad, because multiple sclerosis has its own Charcot triad, just for everyone to know. But that can be invoked as well, and that is because multiple sclerosis causes demyelinating lesions in the cerebellum. So we are seeing right now one problem that is ataxia that can be linked to the cerebellum. We're also seeing nystagmus and vertigo, that are 2 signs that, accompanying with ataxia, increase our pretest possibility of having a cerebellar lesion, although obviously it is not confirmed. Nystagmus is basically rhythmic and not sorry, I forgot the word, but not intentional rhythmic movement of the eyes. And the vertigo obviously is the subjective perception of movement, even though the patient it's not moving at all, it's just stationary. And she also mentions that feeling of diffuse burning sensation. So that can be it actually will depend on the localization of the burning sensation. I will think maybe Arturo, you have a better explanation of that clinical sign, but for now I will just attribute it to to maybe this possible entity that we are discussing. This multiple sclerosis can present also with diffuse burning sensation, and it actually has an eponym, I think, that the Lermite sign. I don't remember. Don't quote me on this, but I think it is the Lermite sign. And on the last 3 weeks, the weakness has intensified up to the point where she's having difficulty walking. So, two things. So first, if the weakness intensifies over the course of months, then we have a progressive weakness, and this nature of the weakness that increases over time, really doesn't really match with the initial initial suspicion that I had for this to be a weakness that is exacerbated with exercise. This fatigability shouldn't have this, shouldn't be referred to as a weakness that intensifies over time. And so, and since we were already considering demyelinating causes like multiple sclerosis, or it is actually not the only differential diagnosis for this acute quadriplegia, but it is a well-known cause of that. Obviously, other demyelinating diseases can be invoked as well, or other focal lesions that preferentially affect the brainstem and cerebellum. But yeah, this progression, in the difficulty walking, makes me want to question if the patient is also having trouble with keeping up with the respiratory rate, and if the patient isn't showing signs of low oxygen saturation, which is one of the main complications that we should assess early in patients who have really extreme weakness, because that weakness, the way that weakness or that motor weakness can really risk the patient's life is by causing respiratory failure. So it is actually something that we are not extreme. We actually, and the neurology world in Peru, it's very aware of this, because one of the main causes of acute flaccid paralysis, which is Guillain-Barré syndrome, is endemic to our region. So we know what it is to have patients that have weakness, and also that need assistance from devices that can improve the respiratory rate and ventilation in the patient, so the patient isn't developing a respiratory failure in consequence of the weakness. But yeah, those are my thoughts. I know I've talked a lot with this piece of information, just because it was a really rich piece of information, but I know you may have more comments to add, so please go for it, Arturo.
Yeah, thank you, Gerardo. So I will also think that this is probably a cerebral disease. I mean, most of the signs that we saw right now are probably generated to cerebral disease. I want to do some comment about diffuse burning sensation. As you said, Lermite sign can explain the diffuse burning sensation, and that actually has a maneuver to elicit, which is when the patient does an abrupt flex of the neck, can present with this diffuse burning sensation. Also, maybe described also as electric type of pain that goes all down from the head to the butt, following all the spine. Other cause that I can maybe think about a diffuse burning sensation is probably, as you said, it will be very important to know if it is in all the body, or if it is in one side of the body. For example, if it is in one side of the body, we can maybe think that a thalamic lesion can present with a type of pain in that side that is known as degenerative Ruiz pain, if I am not mistaken, which is a pain that generates in all the time in the patient that has some type of pathologic disease, for example, a stroke. Other causes about the diffuse burn sensation, maybe some type of small fiber neuropathy, for example, a small fiber neuropathy for uremic disease. Perhaps I can think about that as a diffuse burning sensation. But in this case, as we are seeing it now, it's probably due to a cause related to the ataxia, the nystagmus, and the vertigo. And that is, as I will think, a Lermite sign is present in patients with posterior cordonal disease in the medullary spine. So patients, for example, with tabes dorsalis or with B12 vitamin deficiency can present with Lermite sign. Also, obviously, with multiple sclerosis affecting the posterior cordonal spine can present with Lermite sign. And particularly, this type of presentations in a patient with posterior cordonal disease can present with ataxia because all the proprioceptive information is traveling through the posterior columns in the spine. So it can present with ataxia, it can present with vertigo. Nystagmus is a little bit rare to attribute to a posterior cordonal disease. But I think it will be really important, as Gerardo said, to look at the Romberg test, because finally the Romberg test is what is going to tell us if this patient is having a cerebellar or a sensory deficit. But those are my comments on diffuse burning sensation. And also, as Gerardo said, the beginning of the paragraph, we saw a pattern of a weakness that progresses with exertion, fatigability with weakness, and that is very related to my myasthenia. But I think all the discussion is pointing aside from myasthenia. And also, I wanted to talk about a bit, talk a bit about the respiratory failure. As Gerardo said, that is one of the main things that we have to keep in mind in this patient, because if it is showing signs of insufficiency, respiratory insufficiency, specifically, if we can determine that type of insufficiency as type 2 respiratory insufficiency, we can probably say that this patient is having trouble breathing due to the weakness related to the breathing. So yeah, those are my thoughts right now. I think you cover a lot of the disease that we should keep in mind right now. So I think we can continue with the next piece of information. Go ahead, Jeffrey.
Yes, guys. So I'm really liking it that you organized the information that I'm giving to you, and also that you're already perceiving the need for certain pieces of information in order to advance in your diagnosis or possible diagnosis. So I'm going to review the primary medical history and also some of family history and social history. But also maybe I could go ahead and review some of the general physical exam, not the neurological part, only like the rest of the systems. Would that be all right?
Yeah, please go ahead. And also, Jeffrey, if you can do me a favor, please. So in the lower left corner, you have like a triangle. You can click on that, so the screen can be bigger. Do you see it? Like the little sign next to the 4 squares on your, yeah. So, and then also if you in the top right, you also have the same sign but flipped.
Sure.
That you just clicked. Yeah. So that in that way, and also you can shorten the space of the lower bar. Yeah, amazing. Thank you. Yeah, you can continue.
Great. Okay. A little square here. So the patient has no significant medical history, besides 2 cesarean sections, and she's currently not prescribed any drugs. On her family history, little square here, the patient refers that she has 1 sister and 3 aunts with Hashimoto's thyroiditis, and another sister with rheumatoid arthritis. Regarding her social history, she's a housewife. She doesn't work. She refers to be a social drinker, and only on occasions she drinks less than 90 cc. In regards to allergies, she does not refer any allergies, and the rest of the history was not relevant. Okay, so now about her vitals. We have her temperature, it was on 36.8. Her heart rate was on 105. Blood pressure, 12/80, and respiratory rate was on 19. On her exam, we have that generally she seems to have normal weight. She looks hydrated, not cyanotic, not icteric. On her head, eye, ears, nose, throat exam, there was no sinusitis, and there were no lymph nodes detected on her neck zones. And cardiovascularly, we found no jugular vein pressure sign, so it was not seen on the physical exam. We found no edemas, and her heart sounds were normal, as well as her rhythm. There were also no murmurs detected. Pulmonarily, she has normal breath sounds, and on her abdomen, there were no abnormal findings, so no ascites. And on her extremities and her skin generally, there was no edema, no ecchymosis, or other skin signs that we may present. So I think that's it for now.
Thank you, Jeffrey. I think, Arturo, you can go ahead and start with this piece of information, please.
Yeah, there is really, I think, little pieces of information that we can discuss right now. For example, when I heard that the patient had a sister and 3 aunts with Hashimoto thyroiditis, the question that comes to my mind is, can we relate the weakness to some type of thyroid disease? And I only know what disease that can cause forelimb weakness with some thyroid process, and that is periodic paralysis due to thyrotoxicosis. Any state of thyrotoxicosis can develop in all the clinic forelimb weakness. It's very rare, but it can happen. Other causes of periodic paralysis are related to the potassium. For example, hypokalemia and hyperkalemia can present with periodic paralysis. But if we try to look up that in the HPI of the patient, probably this patient doesn't have a periodic paralysis. That is not the case that we are seeing. We are seeing more of a progressing weakness, nor a weakness that comes and goes. So it's a cause related to the thyroid, but it's probably not the diagnosis of the patient. The rheumatoid arthritis, if we try to relate it to the weakness of the patient for a start doesn't have any clinic of rheumatoid arthritis, but let's imagine that the patient may have rheumatoid arthritis. What cause can be related to weakness? And the first cause that comes to my mind is vasculitis, rheumatoid vasculitis that can present as a polyneuropathy, and that can present as also as a mononeuritis multiplex, and that can present as a forelimb weakness. Yeah, that is what I have to say. Go ahead, Gerardo.
Thank you so much, Arturo. And now that you are mentioning possible complications of rheumatoid arthritis that can cause this presentation, I thought about one more, which is that rheumatoid arthritis is known to cause subluxation of the cervical spine at the level of C1, C2. So that can, when we do a maneuver that involves extending the neck of the patient, it can actually cause to have a more pronounced subluxation, and it can actually compress the brain, not the brainstem, but the spinal cord, and that can present like any spinal cord lesion that depends on the extension, and it can also have a quadriplegia because it is really high up on the spinal cord. But this is not the typical presentation of that. That lesion would be hyperacute, and right now we are having a chronic presentation. And what we are talking about right now is the neurological thinking that we were trying to immerse into our discussion. We were talking about the pace right now, and we were establishing that, okay, so these other potential causes that are, in this case, related to the family history of rheumatoid arthritis can happen, but the accurate presentation or the corresponding presentation would be a hyperacute one rather than a chronic one. So that's how we established the differential diagnosis. And we also use the localization. So up until this point, we were saying that it may be involving a lesion that it's affecting this central nervous system. But since we didn't want to anchor ourselves into this possibility, we were asking ourselves, okay, could this be in the periphery? And I think the potential for it being on the periphery, I mean, I wouldn't say that it is 100% impossible, but I would say that currently I'm thinking more towards possible CNS causes. And the syndromic pace, it is actually a complex syndrome because it encompasses weakness, ataxia, and nystagmus vertigo. And I think that we shouldn't condense it on just one syndrome because there are a lot of coexisting entities and the differential diagnosis is just too broad. But I don't know, I'm curious, Arturo, if you had to name a syndrome for this presentation, what would you consider it to be?
I will probably try to use what it is explaining how to think like a neurologist from Ita Meissler, that basically combines just the pace and localization. And that is, for example, in this case, can be weakness of all limbs, chronic, a syndrome of quadriparesis in four limbs, quadriparesis, with some cerebellar versus with some cerebellar ataxia versus sensory type of ataxia. So that is how I will name the syndrome if we try to put it in a name.
Yeah, I think that the name that you are proposing really summarizes the key points of this case. And from this next information from this new information that we've received, do we think the pace and localization are changing from this new information? Well, I would say that this family history and the lack of past medical history really interest me because, as we were saying, one of the first causes that we have to consider when we have these types of lesions and we are suspecting them to be localized in a very specific a part of the brain, which is the brainstem. Well, we are possibly thinking that. So what lesions can cause that? Well, the first one that we should think, just because of the prevalence, which is the pretest for probability at the end of the day, is a stroke. So we always, in neurology, we are always looking for a stroke, risk factors. So we don't have any mentioned, but that doesn't mean that it is not possible for a stroke to happen. It will just be unlikely, or the pretest probability that we have for it causing this presentation, it's lower. These autoimmune diseases that are presenting have one thing in common. They all involve polymorphisms in this very important gene, which is called the human leukocyte antigen, which is in charge of presenting the antigens that are from the periphery, but are also from our own body. So these diseases can also relate to other diseases that are linked to these polymorphisms. And diseases that we can invoke that are related to them are, for example, NMOSD, which is practically a sister of multiple sclerosis that has a more marked female predominance, which is the case in this patient, and it predominantly affects periventricular areas, which are the so-called los circumventricular organs, which are a lot of them: optic chiasm, area postrema, hypothalamus, etc. And in this brainstem part, it's actually a very typical place for NMOSD to cause lesions. So that is one thing that comes to mind, and also other autoimmune diseases, which are demyelinating, which can also explain this presentation, which would be multiple sclerosis. One thing that kind of puts me away from this potential diagnosis would be that this, for example, in multiple sclerosis, the course of the disease, it's rather intermittent, and it like progresses over time, but it actually has many forms, but that is the most common presentation, right? And in NMOSD we have really a stronger acute attacks, and that are actually also can disappear from some time and then reappear again. So we are not seeing that intermittent course that is usually linked to these types of diseases. So yeah, what else can we comment here? I think we've covered the main findings here. So for the sake of time also, I think we can hear the next audio quote from Jeffrey. Go ahead, please.
Okay, so now we're going to go with the neurological examination. And it's quite a lot. So we have that on her mental status. The patient is alert, oriented. Her Glasgow Coma scale is 15 out of 15. On her cranial nerves examination, we found pupils equal, round, reactive to light, as you probably read before. Extraocular muscles function was normal. Her olfaction was normal too. And her trigeminal pair sensory and motor functions were normal. The rest of cranial nerves was not affected. On her sensory function, we found hypoesthesia of the internal face of the arms, both of them, forearms, both of them, and hands. Hypoesthesia of the lateral side of the right leg, distal to the knee. Paresthesia was normal in the four limbs. In regards to her motor function, using the MRC scale, we found that strength was reduced in both upper limbs. And her proximal was 3 out of 5. Trapezius was 4 negative out of 5. Wrist was 5 out of 5, and fingers flexors was 4 minus over 5. And what I'm talking about both upper limbs. And on both lower limbs, proximal was 4 negative out of 5, knee flexor 3 out of 5, and distal 3 out of 5. In regards to her reflexes, it was found that the patient had general hyperreflexia and a bilateral skin plantar reflex. On her coordination, we found ataxia accented with closed eyes while sitting and on bidepestation. The Romberg test was positive. And we also found an altered bilateral finger nose test. Her heel knee test was normal. And she was found to have lateralization on both sides during point heel. In regards, finally, to special signs, she seemed to have preserved stereognosis and normal tactile discrimination.
I love how detailed this neurological examination is, and I think, contrary to what I was thinking, that we have already mentioned, we have already set the main discussion. I think right now we are going to discuss the main what is going to be determinant for today's diagnosis. So I think in order to be mindful of everyone's time, I think we can interpret this neurological examination in parts, like I will go ahead and review the mental status, cranial nerve, sensory function, and then and also I can cover motor function, and then you can Arturo talk about reflexes, coordination, and special signs. Does it seem okay to you? Yeah. Yeah. So let's go ahead. So this is a very interesting neurological examination, and well, we first start with a patient that appears to have a normal mental status, which really it is an important negative sign to have a preserved consciousness, because as we were discussing, our main suspicion is that is a lesion in the brainstem, and in the brainstem we also have a structure that is in charge of preserving the mental status, which is the SARA, which is called in Spanish, but I won't try and pronounce it because maybe I will have a mistake. But this structure is in charge of coordinating arousal. So this structure that travels in the dorsal brainstem is in charge of arousal, and that's why typically brainstem lesions that involve the more dorsal aspect of the brainstem can present with altered mental status that can actually reach coma. So it is important to know that the patient, it is not the case in this patient, which not like completely rules out a brainstem lesion, but yeah, makes us a little bit suspicious in this case. And what also we have in the brainstem, well, we have cranial nerves, and apparently we don't have any compromise of the cranial nerves. So to invoke a possible brainstem lesion and not having really cranial nerve involvement, it's possible, but it's less likely. So yeah, that is what we can sort of interpret from these negative findings. And yeah, as you can see, there is really nothing more that we can interpret from that, just that it is unlikely for a brainstem lesion. And in terms of sensory function, it's very interesting because it's mentioned that the hyposthesia is in the internal face of the arms. So I think that what the examiner here is reporting is that it's a dermatomal involvement of the sensory function, which is something that we really should consider when we are examining the extremities, because there are actually two things that we really have to know, which are the myotomes and the dermatomes. And the myotomes are this concept of different muscle groups having different neurological representation in the cervical spinal cord. And we also have the difference between the localization of territories, of peripheral nerve territories in terms of sensory function. And so for the patient to have a compromise of the internal face of the arms, I think that is that accounts for the C8 territory. I'm not 100% sure, but I think the C8 dermatome it's right there, just because yeah, am I correct? Arturo, please correct me if I'm wrong. Because I think C2, C3, C4, C5, C6, C8 is the more internal aspect, and then we have then we start with T1, T2, T4, which is in intermammillary line, and so on. Then we continue throughout the whole body. But maybe this hyposthesia, it's referred only in the internal arms, forearms, and hands, which can be a sign of an involvement of just this portion of the spine, which is C8. And it also reminds me of this type of deficit that is a very specific deficit, which is a suspended sensory deficit, or a suspended hyposthesia. And that is because it can be very specific to central cord syndrome diseases, because when you affect the central cord, you can, if you are reaching the anterior white commissure, then you can interrupt the spinothalamic fibers that are traveling from the periphery to the central nervous system. So that can be seen, for example, in syringomelia, which is associated with KRE1 malformation, if I'm not mistaken, or it can be associated with trauma. You can also have this with an ependymoma, for example, which is another a tumor that can present with central cord syndrome. And yeah, NMOSD can also present with central cord syndrome if the right lesion is in place. If we are affecting the anterior white commissure in just one segment of the spinal cord, that can be the presentation as well. So since I am only hearing, I am also reading that hyposthesia of the lateral side of the right leg, distal to the knee. So the lateral side of the right leg, I'm assuming the hyposthesia involves the crude touch, and because there, it can be a little bit tricky to really specify which type of deficit it is, but I'm assuming that it is crude touch of the lateral side of the right leg, distal to the knee. So if it is distal to the knee, it means that it is below L4, L5, which can be S1, S2, S3, which are obviously different localizations than just the C8 localization that we were presuming. And yeah, polysthesia was normal in the forelimbs. So it means that the bigger fibers aren't affected, the small fibers may be affected in this patient. So yeah, I don't know what to come up with if we have this segmental hyposthesia. The central cord syndrome hypothesis loses power because now we have a hyposthesia that involves different territories and it is actually segmental. So I haven't seen that type of involvement before. I think that it is going to be a very strategic lesion for it to cause this type of deficits. And strategic lesions can be seen in entities like multiple sclerosis, which is very well known to cause really particular syndromes, but it can also be caused by other central nervous system diseases like vasculitis, as you mentioned, Arturo. And finally, the motor function. Well, we see a weakness that is not very pronounced, and it is present in the upper limbs and lower limbs. So, and the weakness seems to be it is not mentioned that here is proximal weakness, but I don't know if you Jeffrey are talking about what specific muscles were assessed to describe the proximal aspect of the exam. I'm assuming that you are talking about hip extensors, hip flexors, but yeah, what I can say about the weakness that is reported, it's that it seems to be a diffuse weakness that involves many peripheral nerves, not just one, and this diffuse weakness that, for example, it's not affecting the wrist and it's not affecting the what else? Yeah, that is not affecting the wrist can be. I will actually leave that piece to you, Arturo. I think that can be linked with the other parts of the exam that you are also discussing. So please go ahead.
Yeah, thank you, Gerardo. I am actually very relieved with all the information that we have in the neurological examination, because before we had a lot of questions. The first of those was how will be the Romberg exam of this patient. Now we have the Romberg exam. And I am actually going to start with that one because the Romberg exam being positive defined one of our problems that we had before. That was if our ataxia was cerebral ataxia or was a sensory ataxia. And in this case, we are seeing a sensory ataxia. And to explain a little bit about that, the Romberg comes positive in a sensory ataxia, not in the cerebral ataxia, because in the cerebral ataxia, it doesn't matter if the patient has the eyes open or has the eyes closed, because all the visual inputs will also go to the cerebellum. And if the disease is in the posterior columns on the spinal cord, then that visual inputs can somehow alleviate that information that is coming from the spinal cord, and if it is well processed in the cerebellum, then the patient can stabilize himself and can stand correctly. But if the cerebellum is affected, then it doesn't matter if he has the eyes open, because all the information of the eyes will also go to the cerebellum that is affected. Then it wouldn't matter that. So if in this case it's positive, that means that this is a sensory ataxia. That means one of two things, or either the disease is in the posterior columns of the spinal cord, or it is in the nerves. And at that point, I am gonna talk about a little bit about all the sensory and motor function. When we see all that type of presentations and different levels of weakness in different segments of the body that are not really easily related to some type of dermatome or myotome, the first thing that will come to my mind is to think that this is a nerve diffuse process. For example, a multiple mononeuritis multiplex that can present this way. Another possibility will be probably to think about a polyneuropathy, but that is not the type of presentation in a polyneuropathy, specifically with the sensory function. So the first thing that will come to my mind seeing the sensory and the motor function is to think about a mononeuritis multiplex. And I can a little bit confirm that with the hyporeflexia, because if our disease was in the spinal cord, then we will probably be seeing hyperreflexia. And that is something that actually Gerardo mentioned a little bit before about a case with anterior spinal artery disease causing a stroke in the spinal cord. One of the things that we should look up is a weakness with hyperreflexia. But in this case, we're seeing hyperreflexia. Probably there is no affection in the spinal cord. Otherwise, we will have hyperreflexia. So my mind now goes to what disease can present with mononeuritis multiplex. I don't think that really analyzing the specific findings in the sensory and motor function can help us to the diagnosis, more than just saying that this is probably a mononeuritis multiplex. A little bit more of that. So also we have altered bilateral finger nose test. As I said before, the cerebellum depends on all type of information from the movement of the articulations that will come first in the nerves and then in the posterior columns of the spinal cord, and then will end in the cerebellum. And altered bilateral finger nose test is usually seen in cerebral diseases, but it can also be seen in a patient with mononeuritis multiplex affecting the nerves that are sending this information from the muscles and from the articulations to the spinal cord. The Hinil test was normal. That is also something that makes me say that probably this is not a cerebellum. If this will be a cerebellum process, then probably the Hinil test will also be affected. Also, we have preserved stereognosis. I think one of the things that we can comment about really fast about that is thinking about the central process before we talk about a vasculitis in the brain that can maybe present with a forelimb weakness. Very rare, but it can present it. But in that case, we should look up at hypoesthesia, and in this case, the patient has hypoesthesia. But in brain-related problems with hypoesthesia, it's usually either limb related or either in half of the body. Let's say that again this patient has multiple strokes in all the brain and can present with different patterns of hypoesthesia in different parts of the body. Then the first thing that I will look up in the special sign is an stereognosia, because an hypoesthesia in the brain will usually come with stereognosia. In this case, the patient has the stereognosis normal, so I am really putting in the back of the list any central nervous system process. And now I will say that this patient probably has a mononeuritis multiplex. One of the things that comes to my mind is by her family history, probably vasculitis, rheumatoid vasculitis. That can be one cause of mononeuritis multiplex. Other causes, probably we will try to search more causes with the labs. I don't know if Gerardo, you have more anything more to comment, or we can go to the labs.
Yeah, I think that you made a really important point, which is that, and it is actually a very common clinical setting that I found myself while discussing cases, which is that you have multifocal deficits. And sometimes, as I was trying to do, you try to localize to specific structures, but sometimes what you have to do is just think outside the box and think, okay, this multifocal type of presentation can be attributed to what? Well, as I said, can be attributed to multiple sclerosis, but as you mentioned, it can also be attributed to peripheral nervous system causes like multiple mononeuritis multiplex. So it is something that we should consider. I 100% agree, and that can be, as you well said, associated with the family history of autoimmune diseases that this patient has. And also one comment that I want to do, since this is a case of chronic weakness, I remember that I was discussing a similar case about chronic weakness, and the patient also had ataxia and all other signs of cerebellar involvement. But when we came to the neurological examination, there were lower motor neuron signs, and this didn't make sense for a purely central nervous system cause that we were trying to invoke. Obviously, there is a portion of the lower motor neurons that is on the spinal cord, but the fact that this patient is presenting with multifocal lesions and is also having cerebellar signs can be an indication or can be a pathology that is not restricted to the periphery. It can be a coexistence of central and peripheral nervous system affect, a coexistence of those two, or those two can be involved. What came to the mind of one of the of the people that were discussing the case were this special type of cerebellar disease that actually has this presentation, and it is it was I remember because it was mentioned that it was inside the family of CIDP, of chronic inflammatory demyelinating polyradiculoneuropathies, but I think it is its own diagnosis right now. But yeah, I don't really remember the specific name of the disease, but that is one thing that can be mentioned in a patient with peripheral nervous system signs and cerebellar disease. So far, we've drifted away from central nervous system to peripheral nervous system, and we started considering the possibility of having mononeuritis multiplex. So what is going to be key in this exam, obviously, is the imaging. The imaging, it's going to be very useful to rule out structural lesions predominantly, but we also have to see other aspects of the complete assessment of the patient, which include from notable labs like potassium levels, sodium levels, to the electrophysiological exam that can give us more information about the peripheral nervous system and the nerves that may be affected at the pattern of involvement. So yeah, I'm really curious to get to know more information from Jeffrey. So please go ahead.
Yeah, guys. Okay, so I'm going to present notable labs, which include CSF studies and also hematology studies and serology studies. And there are this is also a very rich chunk of information because there is a lot to discuss. And I really like all the differentials that you've mentioned so far. So we have that her white blood cell count was 8,230. Her hemoglobin was on 13. Platelets levels were on 220, normal. HIV test was negative. Her VDRL test was negative. Her ANA antibodies negative. Rheumatoid factor was positive. Anti-DNA was negative. ANCA negative. Anti-TPO, which is helpful for Hashimoto's, was negative. Her complement levels were also normal, and as well as her ESR and her RCP. And her beta-2 glycoprotein was found on normal values. Chemistry, we have sodium 136, normal, potassium 4. We have bicarbonate 24, boon 42, normal. Creatinine 0.7, glucose 110, calcium 8, and albumin 3.8. On her CSF, the appearance was clear. The glucose levels of her CSF were 52, proteins 284, RBC count 3, and no white blood cells were observed. Gram was negative, and oligoclonal bands were absent. On her panels, she was performed a panel for meningitis, which involved many different possible pathogens: E. coli negative, Haemophilus negative, Neisseria negative, S. agalactiae negative, and pneumococcal negative, cytomegalovirus negative, HSV1 and 2 negative, India Inc. Negative, and Toxoplasma was also negative, and she was also performed tumor markers, which were negative.
Thank you so much. And yeah, I see that we've already discussed like for 1 hour and 12 minutes. I don't know how we've spent that much time. I really didn't feel it. I was just really invested on the case. But to be mindful of everyone's time, I think you can start right now. Arturo, maybe you can comment on one part of the information, and then I'll cover the rest.
Yeah, so I will talk about hematology and other blood tests. There is nothing relevant until we see the rheumatoid factor positive. Now, can we say that with that rheumatoid factor, can we diagnose the patient with rheumatoid arthritis? Obviously, no, because rheumatoid arthritis is neither specific, neither sensitive. So really seeing a positive rheumatoid factor, the only thing that we can maybe try to put it in mind is that previously we were talking about a mononeuritis multiplex that can be explained by a rheumatoid vasculitis. So maybe that can be part of the clinic considered before diagnosis a patient with some presentation of rheumatoid arthritis. Maybe in that case, we can give it a little bit of weight to the rheumatoid factor positive. But as I said before, it is neither specific, neither sensitive. That actually there are a lot of viral process, hematologic process that can present with rheumatoid factor positive. But at least
I just wanted to make a really brief comment to just say that rheumatoid factor it's sensitive but not specific, which means that it detects a broader, a larger population, but it is not specific to one entity because it can be found in a lot of entities. Just wanted to clarify that.
Yeah, thank you, Gerardo. So, yes, sensitive, but no specific. So, Now, I will try to think about other process that can present with a rheumatoid factor positive that can present with this type of presentation in the patient. For example, one of the things that comes to my mind is lupus can present with rheumatoid factor positive. Is this a patient with lupus? Probably not, because it doesn't have any systemic clinic. Other cause is cryoglobulinemia. This patient also doesn't have any sign of cryoglobulinemia, doesn't have any hematology findings, doesn't have any episodes of thrombosis, so maybe not. Viral process can present with rheumatoid factor positive, but if we look down a little bit in the CSF panel, we have a negative for cytomegalovirus, negative for HSV1 and 2, and I think with that, probably only the only possible cause for a positive rheumatoid factor, as the clinic can tell us, probably is a mononeuritis multiplex via rheumatoid vasculitis. I think I will leave the CSF and CSF panel to you, Gerardo.
Thank you so much. And yeah, I agree with what you have mentioned so far. So the things that we should focus on in the hematological panel is in the positive signs, and we really just see the rheumatoid factor being positive, but we also with this panel we can exclude other potential causes, because as we were suspecting of a small vessel vasculitis, the ANC is negative, but it is obviously not. It doesn't rule out vasculitis, but makes it a little bit less likely. Also, the anti-TPO, which is very specific for Hashimoto's, is negative. And the normal C3 and C4, it's assessed because when we talk about vasculitis, it can be immune-mediated. If it is immune-mediated, it can consume complement or it cannot. It depends on the type of immunological reaction. So in this case, the normal C3 and C4 tells us that this probable immunological process isn't complement mediated. And beta-2 glycoprotein, I like that it is featured here because it is one of the biomarkers, specific biomarkers for antiphospholipid syndrome, which can be invoked in this case when we talk about possible causes for hypercoagulability that are not stroke, right? And yeah, in the CSF part, I see something very interesting, which I've seen in a couple of different situations, which is that the proteins are really elevated, but the glucose, I think it's normal. It can vary between labs, but I think it's normal, right, Jeffrey?
Yes.
Yeah, and you don't really see signs of inflammation apart from the proteins, which the proteins, when I think of the CSF, I divide it into two buckets: the albumin and the immunoglobulins, which are also proteins. So when I see this type of presentation, which when there is a large amount of proteins and not really large amount of cells, it may indicate that this process is immune mediated by immunoglobulins, which is different from a process that is mediated by cells. Because one thing is the humoral immune response, and other thing is the cellular immune response. So that can point us towards, for example, CIDP. You can find, this is called actually the albuminocytologic dissociation. And in a chronic presentation, you should raise suspicion for CIDP. And it just makes me think about this differential diagnosis that I mentioned previously about the coexistence of peripheral nervous system disease plus cerebellar signs. It can be the case. But other things that we can consider apart from this can be, for example, a paraneoplastic syndrome, there are a lot of syndromes that can present with this type of information. To the tip of my tongue, I don't have one specific at the moment, but we know that paraneoplastic syndromes have a very wide variety of presentation. So, and they are mostly immunoglobulin mediated. So that's why I am talking about that. And yeah, there are no signs of inflammation, and we have a really good um, infectious panel to rule out that possibility. So yeah, but I think that from what I'm seeing, this is given the flavor of a disease that involves the immunoglobulins, and it is affecting probably the cerebellum plus the peripheral nervous system. But I will carefully wait for the imaging results just to confirm the suspicion, but that's currently where my mind is at right now. I don't know if Arturo, since this is one of the last pieces of information, you want to add something, or should we just continue with the rest of the case from Jeffrey?
Yeah, actually, something that came to my mind about the albuminocytologic dissociation is that apart from CIDP, it can also be presented with transverse myelitis. And at this point, I don't think that we were really considering transverse myelitis, but as you said before, imaging will be some type of key for excluding this and probably focusing on one diagnosis. So yeah, let's go with imaging.
I would expect if this was transverse myelitis, and since it had to involve really upper parts of the spinal cord, then we should see more autonomic signs like bowel and bladder symptoms, which we are not seeing. Yeah, so that is something very important to really pay attention to. The absence of bowel and bladder symptoms in the context of weakness and sensory symptoms reduces the possibility of spinal cord disease. So that actually points us more towards the periphery, I think. But yeah, let's see the imaging from Jeffrey. Or yeah, continue. Go ahead.
Okay, great guys. So I actually have a lot of studies that are like included in this section. So I don't only have imaging, I only have like nerve conduction studies and electromyography. So if I present it, like I will present all of that chunk. I think is that fine? Or I can just first present the imaging that I have for the case, and then present the other part.
One question. So this is the last part of the case, or there is more information?
So yeah, I mean, this is quite the last part.
Because, the next part is going to reveal the diagnosis.
Yeah.
Okay. So I would prefer to receive first the imaging and then the other studies. I don't know if Arturo is right with that. It's okay with that.
Yeah, go ahead.
Okay, great.
Can you do it, Jeffrey?
Sorry?
Can you show first the imaging and then the rest of the studies?
Yeah, I'm going to present them.
Yeah, amazing. Thank you. So in the meantime, yeah, I wanted to say that just Gerardo a little bit ago mentioned it, that actually, yes, seeing no involvement of any urinary and defecatory symptoms puts back in the list the possibility that we are seeing a spinal cord disease. But actually, it also puts in the list the possibility that we are seeing a nerve process, because in nerve diseases, we can also see bladder and defecatory symptoms. And what I have learned is that when we don't see any of those, what we can think probably is any muscular or any neuromuscular junction, or any anterior horn cells disease. But I think that in this case, we probably are not seeing that. So probably we're seeing just a case of a nerve process, or a central nervous system process without urinary and defecatory symptoms.
Great. Yeah, I think that for the purpose of this case, right now we can describe what we are seeing, or should it? No, for the sake of everyone's time, I think we can hear the report from Jeffrey, the description of the report, and then we can comment some thoughts on that. Jeffrey, your mic it's not open.
Oh, sorry. Okay, so the patient was done some MRIs just after like getting attention at the clinic. And as you can see, it shows some areas of like scattered hyperintensities. This is T2, but she was also performed flare exams. So she was found to have hyperintensities in the midbrain, as you can see, but also the anterior and posterior pons. Sorry, this one is the pons, and here is like more like the midbrain. So she's having these hyperintensities that are not so tight, not so like juxtaposed, but they are like more like scattered. And also on the pons, and this is like a reconstruction that also points towards the pons for a possible lesion. And she was also found to have like demyelinating lesions near the medulla, especially in the inferior part. But I don't have images for that. Nevertheless, I think you can barely see it here, maybe if we're like imaginative. So I think that's it for images.
Thank you. The lesions, I'm interested in seeing the spinal cord lesions. It would be interesting to see the transverse incidence of the spinal cord. This is I think you commented that was the midbrain, and then you also found the spinal cord lesions that were, but we don't have a transverse or a cross-sectional incidence of the image, so we can see the spinal cord involvement. Do we have that?
Yeah, and like the spinal cord was not involved. It was more like the medulla oblonga.
Okay. Okay. Yeah, so we have a lot of brainstem lesions, and these brainstem lesions are apparently multifocal, and they are obviously not affecting cranial nerves, which is very it is definitely a typical presentation, but I think the evidence right now really points towards the possibility of multiple sclerosis / NMOSD. I'm saying multiple sclerosis first, just because we haven't seen really the extension of the lesion here, and sorry, let me rephrase. What we haven't seen, it's like a really typical presentation for NMOSD, where you have really extensive lesions that are so-called the longitudinally extensive transverse myelitis, which is a lesion that includes more than 3 segments of the spinal cord. We aren't seeing that. We haven't seen a history of optic neuritis or a history of brainstem syndromes that usually accompany NMOSD, like, for example, when you affect the hypothalamus, you can alter the sleep-wake cycle, and you can have this entity that I just forgot the name, but it starts with N, and it is a sign of the disturbances in the hypothalamus. I will tell the name once I recall it, but we are not seeing that. We aren't seeing also area postrema signs, but we are seeing cerebellar signs, and this lesion can explain the quadriplegia. I think it can, just because the cerebral peduncles are actually at this level of the CNS, right? The structure is the one that contains the corticospinal tracts that are traveling from the cerebral cortex. So that lesion is one of those strategic lesions that we were mentioning that can cause this quadriplegia. And yeah, these lesions, as was mentioned, those were narcolepsy, symptomatic narcolepsy. That's what I was talking about. Well, in regards of the hypothalamus involvement in NMOSD. And it is important when you are seeing MRI studies of these diseases, it is important to order these important sequences, which are T1, T2 flare. Diffusion can be used also if we want to, if we are suspecting a stroke. And also, could this be a stroke? Well, it is reported as demyelinating lesions, but yeah, I don't think this is compatible with a stroke just because of the localization of the deficits. But in a real clinical setting, we will use diffusion weighted imaging just to be sure that it is not diffusion restriction caused by stroke. So yeah, those are my two pieces on this. Arturo, do you have anything to add?
Yeah, probably. Actually, agree. I agree with the probability diagnosis of chlorosis versus an NMOSD, and maybe doing the exercise of what other diseases can cause wide appearing lesions in T2 in those sites in the brainstem. Some of the ones that comes to my mind is first central pontine
Myelinosis.
Yes. But that is an acute presentation in a patient that is rapid corrected from a state of hyponatremia. And obviously, we're not seeing that. But it is very acute. It can cause quadriplegia. Other causes, for example, actually something that came to my mind in this young woman patient, lupus can present as a lupus myelitis, and lupus myelitis can present in two ways: either a great matter in the spinal cord disease, or either a white matter disease in the spinal cord. In the cases of a great matter, it presents in a very fast way, in a very acute way, with hyporeflexia. In contrast, if it affects more the white part of the spinal cord, presents more progressively, and it can present with either hyperreflexia or hyporeflexia. As we said before, transfer myelitis can be in this localization. Probably, we have to keep in mind the possibility that this patient may have lupus. Probably also with the positive rheumatoid factor that, as I said before, can be presented in lupus. So that is one diagnosis that I will add to the list. And yeah, those are my
I think you're right, but also, since we were talking about sensitivity and specificity in the past, one of the tests that we have received, the ANA test, it's similar to the rheumatoid factor in its sensitivity towards its respective disease. So ANA is very sensitive for lupus. So it is a test that it's convenient to perform at the beginning of the disease, and it was negative. But I think about 20% of patients with SLE, with systemic lupus erythematosus, are actually negative to ANA. So it is not completely ruled out. And I think you are right. It is something that we should include in our differential diagnosis. So far, I think we agree on the presumption that this patient may have multiple sclerosis / NMOSD, but we are open to other possibilities here. So in a real clinical setting, what we will do is send serological studies. And the serological studies that we will use, and actually we haven't mentioned MOGAD. MOGAD is something also that we should consider, although the patients tend to be younger and have a more acute and abrupt presentation, which we are not seeing here. And we also tend to have demyelinating lesions also in the cerebral hemispheres, which is not the case right now. And also involvement of the optic nerves isn't really seen, and we aren't seeing the characteristic perinerval edema of the optic nerve. So that is very characteristic of MOGAD in the MRI studies. And so we are considering those diseases, and we also are contemplating the possibility of SLE. So right now, obviously, we want the serological studies, and I think maybe that may be the other part of the information that we will receive. But let's see, Jeffrey, can you finally tell us the final pieces of information, please?
Oh, sorry. Yeah. Well, I really loved your discussion so far. I just wanted to ask you if, like, what other sort of like exams would you perform in these patients? Like, because as you may have mentioned, what we found in the imaging was really not what we would be expecting for like her clinical signs overall. So, like, would you perform any other sort of like exam that could help you with the diagnosis, especially with like all of the diagnoses that you mentioned before?
Yeah, so are you talking about specific laboratory tests or exams that can be performed in the outpatient setting, like a physical exam?
I was talking more about exams that you would perform to like clarify specifically if there a problem on the central nervous system or peripheral nervous systems, or more neurologically pointing towards more like the neurological part, perhaps.
Yeah, maybe
besides
the electromyography.
besides the labs.
Maybe
Besides
the
labs.
electromyography. Maybe the electromyography is an study that we can consider because it can give us a lot of information in regards of the type of involvement that the peripheral nerves have, if they are involved in this process. So it is going to be really important to really exclude the possibility of a peripheral nervous system involvement, especially in the case of hyperreflexia. When we see hyperreflexia, it is very indicative of a lower motor neuron involvement, but it can also be present in the acute setting, but we are here in the chronic setting. So the possibility of a spinal shock, it's really not that high. So yeah, electromyography, I would say, and also some serological studies that were not mentioned, like, for example, vitamin B12 and other nutritional studies can be assessed. And also, for example, I don't see the syphilis panel. Oh no, you did syphilis panel. So yeah, I think this was a really complete assessment. And obviously in the physical examination we can always include more, but right now, to the top of my tongue, I don't really have one specific thing, just because these entities, in order to differentiate them, and I'm talking about multiple sclerosis and MOSD, the preferential study to do so is the MRI, because it is more specific and it can really describe in detail the lesions that the patient has, which are not always correlated with the clinical presentation as was seen here. But yeah, let's receive the more information about the case.
Okay, so as I mentioned on the MRI, she was found to have scattered hyperintensities in the midbrain, anterior and posterior pons, distal medulla oblongata, but also the spinal cord, which I forgot to mention, but on the C2 and C3 levels and C6. So like scattered all along, but I don't have images for this one. She also was performed an EKG and chest radiography, which were found to have no abnormalities. On the electromyography, she was found to have abnormal distal latency with very low amplitude, no F waves, and numerous spontaneous waves, which pointed towards an axonal demyelinating polyradical neuropathy pattern. She also was performed nerve conduction studies, which found that she had deterioration of nerve conduction velocities, especially in the legs, with acute denervation in muscles innervated by the roots C3 and C4, and bilateral C5 and C6, and right L4, L5, S1. Is there anything you want me to clarify? I can help you out.
Yeah, please, because in the electromyography we see axonal demyelinating polyradicular neuropathy. So it was actually described like that, axonal demyelinating?
Yeah.
Okay. Yeah, it may be from low experience on my end from reading electromyography studies, but one of the things that it is useful for is to differentiate between axonal and demyelinating causes of a peripheral nerve involvement. So if we have a coexistence of those, that makes it maybe not that useful of a tool, because it is not really telling us if we can invoke axonal versus demyelinating. But how can we advance from what we have seen here? Well, in the is there something that tells us that this is in the periphery? Obviously, yes. In the electromyography, we have a polyradicular neuropathy. So it is something that is objective. Like this test is telling us there is actually a peripheral nervous system involvement. And the nerve conduction studies are telling us that there are some signs of denervation, of scattered denervation, right? Because we see in diverse territories, in C3, C4 roots, bilateral C5, C6, and right L4, L5, S1. This can, so far we were considering the possibility of multiple sclerosis and MOSD/lupus. And well, this peripheral involvement, it's not compatible with NMOSD or multiple sclerosis, just because these are diseases that affect the central nervous system. When we talk about multiple sclerosis, it is a lesion that affects the oligodendrocytes. And when we talk about NMOSD, it is a disease that affects the astrocytes. And both of them are cells that are restricted to the central nervous system. That's why they don't have peripheral nervous system involvement. And yeah, so with that being said, that there can be a coexistence of syndromes affecting this, or it can also be the result of a vasculitis affecting the brain. And although there was a clear report of the lesions being called demyelinating, which shortens the possibility. But if that was not rightly reported, I will also consider other non-demyelinating causes, because vasculitis is a phenomenon that is caused by, after all, ischemia of the tissues. So we should see diffusion restriction. So that's what really, well, I'm having trouble to reconciliate. But yeah, I will definitely consider the possibility of this, and I will improve what has already been done in terms of notable labs. I will also include other studies that can that are more sensitive / specific for these diseases that I'm invoking. But right now, I'm leaning towards a possible coexistence of diseases, or one disease that can explain it all could be vasculitis, or this cerebellar involvement that I was invoking a few minutes ago. So Arturo, what do you think about this last set of data?
Yeah, as you said, now it's very complex, because now we have all the case we were trying to say if this was a central or a peripheral case, and now with imaging and all the rest of exams, we now are seeing that this patient probably, well, not probably, this patient has something in the central nervous system and also in the peripheral nervous system. So now probably we should think about things or diseases that can cause central and peripheral diseases. Clinic in the central and the peripheral nervous system. For example, lupus, as I said before, can explain the transfer myelitis. It's ANA negative, and that's probably one of the things that I will do. Repeat the ANA. If it comes positive, then probably I will increase the probability of this is a lupus. The lupus can also cause the axonal polyradicular neuropathy. Now, also, I wanted to comment the same that Gerardo mentioned it. Axonal demyelinating polyradicular neuropathy is reported in the EMG. I have seen in the Hospital 2 de Mayo that description in some EMGs, but as Gerardo said, it is not useful because one of the differential diagnoses that comes with a polyradicular neuropathy is to say if this is axonal or if this is demyelinating, because there are different processes that can explain each one of those. And now with the axonal demyelinating polyradicular neuropathy, that thing that comes to my mind is to look up to both axonal and to both demyelinating diseases. So the axonal one can be lupus. One of the demyelinating ones that comes to my mind is B12. B12 deficiency actually is, I read it a couple of weeks ago, is one of the diseases that can present with multiple different symptoms and signs in the central and peripheral nervous system. The most common one is the affection of the posterior spinal cords, but it can present also as a dementia. It can present as a demyelination in the nerves. It's actually a very diffuse process, and I don't know if we should browse now or look up into a B12 deficiency, but at least in the labs we don't have yet the B12 levels, so probably that's why I'm thinking about a B12 deficiency. Now, other causes of peripheral and central disease can, for example, be some infections. We have ruled out a lot of infections. For example, syphilis is one of the ones that will come to my mind that now is excluded. Others that are not yet excluded are, for example, hepatitis C virus. It's one of the diseases that can present as an axonal polyneuropathy. I don't know if it will cause any disease in the central spine, but at least a polyneuropathy type axonal it can present. Yep.
I think it can cause transverse myelitis. I think it is it part of the transverse myelitis panel, I think.
Yeah, amazing. Then FC probably. Other bacterial process that comes to my mind is Lyme. Lyme actually can cause a lot of things, and one of them is axonal polyneuropathy. Also, transverse myelitis can be presented with Lyme. So those panels we are not seeing. So probably that's what I will order. And actually, that is all that will come to my mind now. I don't know if Gerardo, you have something to add.
Yeah, one last thing I want to ask. I don't know if it's going to be the last, but one thing I've thought about, it's when like stressing the fact that this is possibly, or this could be, a disease that involves central nervous system and peripheral nervous system. So one thing that came to my mind is trying to remember when I see a patient that has involvement of the brainstem, because it clearly, the patient really has. So there has to be a disease that explains these lesions. And one of the diseases that I was thinking about was the Bickerstaff encephalitis, because it can also have central nervous system involvement, and it is actually one of the rare types of the Guillain-Barré syndrome that is linked to GQ1B antibodies, that these special gangliocytes that are special to this location. I know that Bickerstaff encephalitis can cause that, but the lack of cranial nerve involvement is really astonishing. I really wasn't expecting that from the imaging. So yeah, I'm curious to know if the opinion of a neurologist, if the neurologist will consider that possibility. And one other thing that I can add, well, and also one thing I wanted to mention is that Bickerstaff encephalitis, to my knowledge, it presents more in an acute pace, and this is a chronic disease, so it makes it less likely. So I just don't want to forget to mention the possibility of having or the approach that I was trying to have in this case, which was that if there is high protein, it can be a sign of an immunoglobulin mediated process, and that can evoke the autoimmune diseases. So if I had to guess, I would guess that this is a case of a immune mediated process in a middle-aged women that presents with central nervous system involvement and peripheral nervous system involvement, and that can be a buzzword for a lot of things that you were mentioning, like SLE. It's something that we should consider. Vasculitis is something that we should consider, and it's broad differential diagnosis. Other example of what we should consider is these infectious diseases that you were mentioning, especially Lyme. It's something that we should consider, although in our context it's less likely because Borrelia burgdorferi is not endemic here, but it is in the global north. So it's something important to consider. And yeah, I think that's all I have to say from the case, and I think we can now receive the final diagnosis, especially because we've spent 2 hours here, and we are actually very thankful to everyone for sticking with us for 2 hours listening to our differential diagnosis and our thoughts out loud. We are really thankful for you, and we really look forward to seeing you in the next sessions, because we really try to encourage everyone's participation. And yeah, if you want to participate in these types of academic projects, you can reach out to us, and we can see how you can get involved here. So Jeffrey, please give us the final piece of information and the diagnosis of the patient.
Yes, guys, so I just wanted to point out that you did it really great. I really loved all the diagnosis and all the thought that you put out to come to like a final diagnosis or to finally represent the whole problem. So we have as the problem representation, again, to summarize the whole case, a 47-year-old female who had no previous medical history with progressive chronic weakness of all limbs, with albuminous cytological dissociation on cerebrospinal fluid and axonal demyelinating pattern on electromyography. Okay, so with that, I'm going to reveal the diagnosis. And because of the sensory motor deficit, I don't know if you can see it. Yeah, you can see it. Because of the sensory motor deficits, clinical course, and cytological protein dissociation in CSF, which were all mentioned and discussed accordingly, the patient was diagnosed with CIDP, or chronic inflammatory demyelinating polyneuropathy, with involvement of the CNS, as evidenced both clinically and radiographically.
Nice. So it was mentioned. I'm really happy that it was mentioned and discussed, and really interesting. Yeah, if you can comment further about the case, please.
Yeah, sure. So this patient again had both motor and sensory deficits, and as one of you mentioned, the course was chronic. So we have like 3 weeks of progressive weakness, and because of that, we can think of certain causes, right? And all of these can point out certainly to like a demyelinating process or like a problem with the nerves. And you can think of like GVS or Guillain-Barré syndrome for sure. But as you've mentioned many times, because of the chronic course, you can rule out that. And also you have like acute inflammatory demyelinating polyneuropathy, right? Which is like the acute form of CIDP. And actually, it's like it can transform into CIDP. And one thing that is always mentioned is that when you have a Guillain-Barré syndrome, which is far more common in our country, in Peru, and it does not respond to treatment, and it actually like regresses or like has like another attack, the patient has another similar attack, then you can sure think of CIDP as a possibility. In this case, the patient had like more like a progressive course. It is also very notable that you've mentioned lots of causes of neuropathies and polyneuropathies in general. I like that you mentioned mononeuritis multiplex, you've mentioned vasculitis, and also like we've like excluded HIV from the possible cause. And something that was very, very pretty, especially for the ones that like to have like the whole picture is that sometimes gamma monopathy, like gamma clonal
monoclonal
gammopathies can also
gammopathies.
cause neurological problems. But and we have, for example, the POEMS syndrome, right? So the POEMS syndrome is, for the surprise of all of us, like the main differential diagnosis of CADP. But for that, you would have to have, of course, like endocrinological alterations. That is why I pointed out the glucose, and also because of the well, she didn't have any like thyroid issues. You could also say that she didn't have like organomegaly. She didn't have well, she wasn't performed like any specific exams for POEMS, and also like there was no skin issues. So for that, like you can like think of that like as probably if this patient is not responding to the treatment for CADP, which is like as many other immunological disorders, IVIG, corticoids, and also maybe azatropine, etc., then you can think of like POEMS syndrome. So that would have to be like discarded. Also, we have the cytological protein dissociation in CSF that is always pointing us towards like Guillain-Barré syndrome. But because like this is a more chronic disease, then sure we would have to think of like other causes like this one. In the realm of polyneuropathies, which is very broad, you have to like think of clinically first if it is a non-length dependent polyneuropathy, which involves both proximal and distal muscles, and a length-dependent polyneuropathy, which involves more like the distal part of the body. So in this case, we would have both of them. So it would be a non-length dependent polyneuropathy. And actually, CADP has many different forms of presentation, just as Guillain-Barré. And like, for example, in the Birkenstock encephalitis in the case of Guillain-Barré, right? And for the case of CADP, the most classical presentation is the one in which both sensory and motor functions are affected, and also the clinical course, of course, and the fact that you may have also autonomic symptoms, which the patient did not have. But I really love that you mentioned that it could be found on patients that had like like an affectation of the nerves. Okay, so now talking about like the central nerve system, I picked out this case specifically because it had both affectations of like the peripheral and central nervous system. And actually, the pathophysiology of CADP is very unclear at the moment. And the way in which it affects the central nervous system, the authors just mentioned that it is because there are some proteins on the myelin that are also found, on the myelin sheaths of the peripheral nerves that are also found on the central nervous system. Like in this case, the patient had like radiologic alterations that did not correspond to the clinic that was found, except for maybe the nystagmus ataxia, right? That probably, like especially nystagmus at vertigo, that was not explored further on the physical exam, but nevertheless could be attributed to like the central nerve system affectation. So in this case, it can happen because it's like a demyelinating disorder, so it can affect also the central nerve system. It is a weird presentation, sure, but I just wanted to point it out because I was curious to know like what sort of discussion would come up from having this sort of clinic presentation that is so uncommon. So I don't know if you guys have anything to add or maybe ask.
Amazing, Jeffrey. I love all the teaching points that you highlighted during your intervention. And yeah, and now I think for the last part, I promise, of this session, we will hear about the teaching points from Sandra. Not all the teaching points, but just the main ones. And the purpose of that, prior to listen to Sandra, is that we actually, if we had to summarize this case, we started with a weakness, and then we had a lot of thinking that ended up having a really narrow differential diagnosis and a final diagnosis of CIDP. So how do we go from from the chief complaint, which is weakness, to the final diagnosis, well, that is what we are going to dedicate our whole lives to learn, right? To appropriately locate and diagnose patients. But there are for sure certain pieces of information that should be highlighted here that everyone that wants to take away learning from this has to know. So in order to highlight those aspects of our discussion, please, Sandra, mention the teaching points that the main teaching points that you highlighted, and then Jeremy will proceed to elaborate the schema for today's clinical case, and it will be published later this week. Okay, and that will be all for today.
Yes, thank you. Well, I think we should analyze the chief complaint, which is weakness, and as all the discussion was about, first we have to assess if there was neurological or no neurological causes. For example, we can think about metabolic causes like azotemia, or maybe thyroid disorders, or maybe some electrolytic causes like hypo or hyperkalemia. Maybe we could think about also autoimmune disease like that will cause polyneuropathy, like vasculitis, like you already mentioned. And also there could be weird causes that you also mentioned, like rheumatoid arthritis, which could lead to this type of weakness, like that the patient have, like quadriplegia. But also there is another causes, for example, neuromuscular junction causes like myasthenia gravis, which is will present as fatigable weakness. And so this is about the non-neurological causes, for example. But in the neurological causes, we should divide this in the central nervous system causes and the peripheral nervous system causes, which in this case we have both manifestations, right? And about the central nervous causes, we could think about stroke or a cerebral vasculitis, or maybe the lock-in syndrome. And if we think about brain lesions, then we can go by brainstem lesions like bonding compressions for an hematoma, tumor, abscess. And also about we can think about the demyelinating disease that could affect the brainstem, of course, like in MSD and multiple sclerosis. And going further, we could think about spinal cord. So this is like an anatomical point of view about the causes of weakness that you mentioned. Then we could think about peripheral nervous system like Guillain-Barré syndrome, which is very common in Peru, and CAPD, which is the diagnosis now, and mononeuritis multiplex. And well, this is maybe the approach for weakness, but based on the findings in the physical exam, like we made in the discussions, we can assess of differential causes. Like, for example, we have found that the patient has ataxia, nystagmus, vertigo, so we think about a cerebral dysfunction. And also we found that she has this hypoesthesia, which we could think about central core syndrome, or maybe we could think about, we also could think about cerebral causes. And about these other manifestations that she had, like burning sensation, we can think about multiple sclerosis, of course, thalamic sensation. And in the Romberg test also give us the diagnosis of sensory ataxia. So with the findings in the physical exam, we could go in further and find which syndrome or which system is affected. So that will be the main points about the physical exam. Maybe another things that I can mention is about the albuminocytology dissociation, which I think is important to mention because it is associated with immunoglobulin process, like CIPD in this case, and that the rheumatoid factor could be positive in multiple diseases, like autoimmune diseases, chronic infections, also and it could be positive in healthy patients, as you mentioned. So in summary, that's how the exam findings and the laboratory exams could help us to go to find which the final diagnosis, like in this case.
Thank you so much, Sandra, for your wonderful teaching points. And thank you so much to everyone for sticking with us to the end of the session. I really enjoyed discussing this with Arturo, and I think we did a good job. And this just goes to show that even though we are just medical students, we can collaborate on projects like this, and we can learn collectively. So this session is going to be uploaded on YouTube, and you are all going to be able to review it retrospectively to see just to have a documentation of how we improve this project, and also to have our content available for everyone. So yeah, as I said, thank you so much. I don't know if Arturo, you have a closing statement to end the session, but that will be all in my part. Thank you so much, and we'll see you in the next Thursday in 2 weeks, since this project is aimed for a 2-week period between sessions, and we are going to see each other the December 26th, 2024.
Yeah,
go ahead,
exactly.
Arturo.
Yeah, no, I just want to thank Jeffrey for this amazing case. It is actually very useful to learn that this is mainly focused as a peripheral process can also cause central disease, like in this case, a CIDP causing presentation in the brainstem. That is really amazing. Thank you, Jeffrey. Thank you, everyone, for assisting this session, and I hope I see all of you in the next 2 weeks, as Gerardo mentioned it. So that is all for today. Thank you, everyone. See you in 2 weeks.
Goodbye. Thank you so much, Alicia. Hope to see you in the next sessions. Thank you, Wendy. Goodbye.
Thank you.